So welcome everyone. Thank you so much for joining us today. My name is Hannah Thomas and I'm the research coordinator for the AWS National Med Student Committee. And I'm joined today by Mary Siki, our associate research coordinator. And we're really delighted to be here. So today represents the third installment of our AWS Research Methods workshop series. We kicked off the series in September and November with our workshops on qualitative methodology in clinical trials, and we plan to continue this series on a bi-monthly basis. If you missed the previous workshops, not to worry, you can check them out on our AWS YouTube channel. But we're very excited about the opportunity to come together today and build our internal and external research capacity by learning from some of the best experts in the field. So today our workshop is focused on survey methodology. So we will begin with a lecture from Dr. Care and Brasel. Dr. Brasel is a professor of surgery in the Division of Trauma, Critical Care, and Acute Care at OHSU, as well as the General Surgery Program Director. Dr. Brasel authored the JAMA survey methodology paper that we sent out via email, so we are incredibly honored to have her here with us today. She will begin with a presentation and we will moderate a Q&A afterwards, but please feel free to post questions in the chat as we move along. So thank you so much, Dr. Brasel, for being with us here today.
It is truly my pleasure. I am going to start by sharing my screen or sharing my presentation. I'm also going to say that I am a very informal person. So I'm happy, and I have my chat up. I've gotten to the point that I can pretty much look several places at once. And this platform is wonderful because we're all in different places in the country. I'm going to assume, I know at least a couple of you, and we can all be together. It is also very artificial and it reinforces the stereotype of the worst type of education, particularly for adults. One person spewing information at another. So I am going to ask some questions. When I ask some questions, I'm going to monitor the chat and I encourage you to use the chat and at least maybe we can have a little bit of a dialogue, albeit artificial that way. I'm also going to say I have a practice of active gratitude and I like to try to start many of the things that I do sharing that practice of active gratitude. Which in my translation is I share three things that I'm grateful for at any particular time. So today, I am grateful that last night I was also on Zoom with my family, my brothers and sisters and their spouses. My parents gave us a Zoom cooking class for Christmas. Focusing on experiences rather than things. And my niece is a very good chef. And so she taught us all how to make fancy Caesar salad with anchovies. Although there was a run on anchovies in Portland and we had to substitute capers, but everybody else had anchovies across the country. Tuna and mango mousse. So, that's number one. Number two, I am grateful for the AWS for what it has meant to me in my career and for the networks it has given me to help residents when they have had questions that weren't either not in my specialty. I could hook them up with somebody else who had walked a similar path. So I'm very, very grateful for the AWS. And I'm grateful for all of you, particularly as we finish the interview season. I know not all of you are finishing your medical school journey, but you'll get there at some point very soon. And I'm grateful for all of you and the chance to have had the opportunity to talk to many of you throughout this process. So hopefully you've had a chance to think of things, a few things that you all are grateful for as well. We're going to dive right into surveys, and this is very, very, very topical. There is a huge debate going on right now about surveys, a survey or two surveys, depending on how you slice things, that the residents are being asked to answer at the end of their in-training exam, which is a 5-hour assessment of knowledge, formative assessment of knowledge. That is its intent, but they're being asked to answer this survey at the end of a 5-hour exam. 67 questions, guaranteed it will only take 5 minutes to answer. So that is a huge national debate right now. I also, for the Journal of Surgical Education, reviewed a couple survey-related papers yesterday, and I can tell you people still do things very well every day of the week, every week of the month, every month of the year, and then they still make the same mistakes every day of the week, every week of the month, every month of the year. So the first question, the very first question, when you think about doing a survey, and really when you think about answering a survey, is it worth your time? Your time is incredibly valuable. Is it worth my time answering this survey? But we will spend most of the hour, 45 minutes, thinking about things more from the researcher perspective. Why would you want to do a survey? As opposed to a clinical trial, going and sitting on a highway and observing people, or probably more relevant, sitting in the operating room and observing a checklist, the direct observation method. Why would you want to do a survey? What information can you get from a survey that you can only get from a survey and you can't get from anything else? Or what information can you get from a survey that is best obtained from answering via survey methodology as opposed to some other aspect? So yeah, surveys can be really cheap as opposed to paying somebody like one of you to sit in an operating room and do direct observation. Surveys can be very cheap. So if you can get the information that you want from a survey perspective, especially online, SurveyMonkey, or some other, I didn't say from a disclosure perspective, I'm not advocating SurveyMonkey over any other online platform. But it definitely can be time saving. It really depends on what you want to know and what you want to do with the information. So really, yes, people's clinical experience or opinion. You cannot get my opinion any other way than a survey. So if you want to write about or want to get, whether you're planning to publish this or not, my opinion, you have to use a survey. There is this great, it is not great. There is this well-known survey of fellowship directors that is used as the gospel truth about chief resident experience. And they surveyed fellowship directors about how competent chief residents were. Well, if I'm a minimally invasive fellowship director, I'm not, I do everything maximally invasively, but if I'm a minimally invasive fellowship director, I do not want to say that the resident that comes to me at the beginning of my fellowship doesn't need my help. So of course I'm going to say that they need additional training. Why wouldn't I do that? Because otherwise they don't need my fellowship. And so that survey, which is used as an example of what the competence of chief residents is a survey of the opinions of fellowship directors. Now, that's the only way to get the opinions of fellowship directors, but it's not the only way, and I would argue not the best way, to assess the competence of chief residents. So I also, I probably get 3 surveys a day, but at least one every other day asks me about the opinions of my residents. I don't know. And now they've gotten a little bit more savvy and they say, well, will you pass this on to your residents? And that has some really huge implications for response rate and non-response bias and calculation of response rates that we'll get into a little bit later. But yes, one of the other, I first got into surveys as related to patients. And if you want to know how patients are doing, you have to ask patients. You cannot ask surgeons. Surgeons will watch a patient walk across the room and say, that patient's fine. Done with my clinic, return PRN, go see your primary care physician. We do this all the time. That does not mean the patient's fine. That does not mean the patient has recovered from their traumatic injury. That does not mean the patient is able to go back to work. That does not mean the patient has access to care. That patient may not be fine, but we look at the wound and we look at their ability to perform something in our mind that is associated with doing well, and that doesn't tell the patient's whole story. So if you want to tell the patient's story, you have to ask the patient. It's also really important when you start down the survey journey to know what you want to do with the information. So if I want to improve a rotation, I'm going to survey my residents, right? Because I want my residents' opinions. I don't want the faculty's opinions, because if I survey the faculty, they're going to tell me everything is fine. And it's probably, even if it's fine, it probably could still be improved. I don't necessarily need a huge response rate. And I'm not necessarily, in fact, I'm not going to publish the information. I just want to know the information so I can do my own development, either faculty development, resident development, change the rotation, improve the rotation. And if I only get 5 responses, we've got 83 residents in the program. If I only get 5 responses, that's okay. And if it's only 5 responses from the most disgruntled people, that's still okay, because it doesn't need to be representative. I'm looking for anything that I can do to improve. So you really have to know what you want to know and what you're going to do with the information to determine whether the survey is the right thing to do and how you're going to deliver it, who you're going to get the information from, and what your response rate needs to be. So surveys are really good, as we talked about, for patient-reported outcomes, assessing opinions or beliefs, and actually comparing beliefs to actual practice. So from time to time, I get a survey that asks what the percentage of penetrating trauma is in our institution. Well, that's actually unknown. And I answer, and I usually answer somewhere around 10%. And I'm accurate within about 5 to 8%. But that's actually known information. Trauma centers keep track of every single patient that comes through the door. They keep track of the mechanism of every single patient that comes through the door. And so we know that down to the actual decimal point, we know the percentage of penetrating and blunt trauma. And you know who knows it really, really well is not the trauma director or some random trauma surgeon like me that practices at our institution. Our trauma program managers who know these data inside and out, and our trauma registrars. So if you're interested in the percentage of penetrating trauma at trauma centers across the country, rather than survey random trauma surgeons or trauma directors, you can either go directly to the trauma registry. That might be a little time and labor intensive, and surveys, as was already brought up, are a little cheaper. But at the very least, you can survey the person closest to the data who works with the data all day, every day. You can also compare beliefs to actual practice or direct observation. And this is absolutely, it can be absolutely mind-blowing what somebody believes they're actually doing and what you can document they are actually doing in practice. And for a topical example, there's a practice going on right now, or a trial going on right now called SAVE-O2. And the objective of the trial is to use the least amount of oxygen to maintain somebody's oxygen saturations above 92%, even if that's putting them on 21%, even if they're on the ventilator. So we thought we were doing a really good job of this before the trial started. And we're like, yeah, we do this all the time. We're not going to be able to get any better with the trial, but we're part of this cooperative network. So that's great. We will, we'll do it, but we're not going to learn anything, and we're not going to be any better because we're already doing this. We were doing it 10% of the time. And we now actually have the data to show that we are doing it 60% of the time, direct observation, compared to our belief, which is how we would have answered a survey, that we were doing it 100% of the time. So prior to the survey, we would have answered probably 90%. We don't think we're perfect. We just think we're pretty good. We were actually 10%, and now we're 60%. So this comparison surveys can actually do well in that arena. And sensitive subjects. If there are things that people are not really interested in talking face-to-face, or talking to a research assistant or somebody that would enroll them, they are more likely to answer an anonymous survey. And surveys are really bad for defining actual practice. Don't ask me what I think I do. You're going to actually have to find out another way of finding out what I actually do. Do you close contaminated wounds? No, I never close contaminated wounds. That's bad surgical practice. I was taught that as an intern, which was a very long time ago. That leads to wound infections. Well, we close about 40 to 50% of our contaminated wounds. We get away with it most of the time, but I will answer a survey in a particular way because I know what the answer is supposed to be, either because it's the socially acceptable answer or because I know it's the textbook right answer. There's another place that surveys have a difficulty. And they have difficulty in both both overestimating and underestimating. If you ask me if I'm comfortable doing something, I'm probably not going to be right on with whether I can actually do it. I'll either tell you I'm more comfortable, and direct observation or using some external data source would show that I'm overconfident, or I will say, I'm not comfortable doing that. And then you could do direct observation and watch me day over day over day and say, I don't know why she answered it that way. She's perfectly competent in doing that. So this is a nuance to the comparing beliefs versus actual practice. Surveys will survey or assess for comfort, but the words they use are competence. And you need to be very, very careful when you use the words. The only thing you can assess for is comfort. You cannot assess for competence. And surveys are not usually very good at detecting small differences. Oftentimes because at the end, you have to combine categories. So you combine strongly agree and agree. You combine neutral with, if you've used a neutral option, and we'll get to that a little bit, you'll put that on the positive or you'll put that on the negative. And so they're often not very good at detecting small differences. They might be good for a lot of educational topics. However, they're used way too often in education. And it is one of the reasons that education science gets a bad name. I develop a curriculum, spend a lot of time developing the curriculum. It's in an area that the residents have told me that they are really hungry for information and they really want that information. And so we go all out, we get resources, we do an online component, we do a didactic component in person, and then we do a skills component. And then at the end, I asked the residents if they liked it. If they thought it was valuable, slightly better than if they liked it. If they learned something, and what do you guess the answer is going to be? They liked it. They learned something. They thought it was valuable. And that they enjoyed every single minute. Of course they did. They told me they wanted something on this topic before we started. I got a whole bunch of faculty, probably the better teaching faculty, to commit time to spend with the residents, one on small group. I could have been teaching them about the Eiffel Tower and they would have been happy, because they told me they wanted to learn about the Eiffel Tower, and then I got a whole bunch of faculty to spend a lot of time teaching them about the Eiffel Tower. And it might not have made any difference in the long run. It would have been good team building, good morale building. I'm not saying it was a bad investment, but survey design on satisfaction does not show that that was a worthwhile investment of time into the curriculum. Change in behavior, change in practice, shortened amount of time to attainment of skills, durable change in knowledge, those types of things, some of which can be assessed by survey and some of which can't. That is a reasonable way to assess a new curriculum. Just a simple survey on satisfaction and value is not enough. And then how are we doing? Sometimes surveys can be pretty good. How are we doing? How can we do better? What suggestions do you have? Surveys can be very helpful there. But you do have to be very cautious about the trap of, I'm asking you something you've already told me that you want to see changed, and I'm asking you how you want it to be changed, and then I change it, I know what the answer to the survey is going to be before I even ask it. So we're now going to move to respondents, or who you ask the questions to. We already talked about my getting a survey that wants resident opinions. And then do they, when they send that survey out, am I the respondent? Do they ask me how many residents are in my program to know what the denominator is? So you really have to know that the person you are sending the survey to is able to answer the question. If we send a survey to the entire faculty about promotion, good idea, bad idea? They want to know about the promotion process. No, it's not a good idea. The professors have already gone through the whole promotion process. So if you're asking what they need to know about promotion, they don't need to know anything. And if you're asking, did they know enough when they went through, the assistant professors can't answer. So you would think, yeah, I can send out a survey about promotion to the faculty. That actually sounds like a reasonable idea. No, it's not a reasonable idea until you get down to the specific question and target the specific faculty. Do you have access? Again, do you have access to faculty? Do you have access to patients? If you're going to send this survey by mail, how do you know everybody has an address? Oh, well, everybody has an address. When they come to the hospital, this is going to be a post-hospitalization survey, and I'm going to send the survey out to the address that's on file in the electronic medical record. Okay, sounds like a reasonable idea. That field is filled in for everybody in the electronic medical record. Sometimes it's a gas station. Sometimes it's a 7-Eleven station. Sometimes it's the jail. Sometimes it's their brother, mother. So you don't necessarily have the access that you think you do just by pulling, oh yeah, this field is full. Do you have the correct electronic access, emails or other platform? And then another thing to think about is, do you have leverage? And I think Margaret talked about this, buy-in and engagement. If I have a resident that is, and we want to survey the residents for something, and I have a resident that will get up and actually use their social capital with their colleagues and peers to say, we really want you to answer this survey. That's a whole lot better than me doing it. They're a whole lot more likely to answer if the residents are the ones that are asking them to do it. And so when we do a survey of the residents, the resident council, it comes from the resident council rather than the ACGME one has to come from me, but any other survey comes from the resident council. There are two questions, one about using social media as a platform. We will get there very shortly. And I've got a couple slides on response rates, so we will get to that question as well. But before you get there, or as you are getting there, think about access. Phones the same way. Can you get phone numbers? Do they have access to whatever platform you are going to use, or platforms you're going to use on social media? There's a Stanford has done a lot of work on surveys with patients and iPads, and they give an iPad, or they use a cell phone or some other. That didn't work in Milwaukee. It was a completely different. We were surveying a. They were surveying a very a group of patients that were highly resourced and had excellent access to care. And we were surveying a group, same topic area, that had very little access to care, no trust in the healthcare system at all, and very did not have the resources. And if we gave them some resources, they were probably going to use those resources to eat or to pay rent, rather than to access the survey, even if it was that they were going to sell the piece of equipment that we gave them. And so you really have to think about that as it relates to your question. So, and I do promise we'll get to social media and response rates, but what questions you ask is really, really important. And people fall down all along the survey pathway in terms of adhering to good survey practice. This is probably where most people who do the rest of the stuff well, they don't think about this at all. So you're going to survey and pick a topic. I'm going to survey patients about quality of life. So what questions should I ask patients about quality of life? And how do I figure that out? I'm really, really passionately interested in it. I've not actually ever been a patient, other than, well person visits, and I had a cyst on an ankle removed once. That doesn't really qualify me for a post-significant hospital experience. But most of the time, you actually have to talk to patients. And yes, if there is a valid questionnaire, 100%. Letitia Campos, 100%. If there's a validated questionnaire, absolutely 100% use it. And you know what most of us do? We take the validated questionnaire and then we say, well, but there's like 3 more things I'm really super interested in. Or I really just want to change this question a little bit. Destroys the validity. Totally destroys it. It may be worth destroying the validity. Those 3 questions, or the change that you make, may be really important. But you have to understand, when you change a questionnaire, you have to revalidate it. So yes, you have to talk to patients, and you can substitute. You have to talk to students if you're going to survey students, or you have to talk to residents, or you have to talk to your group of interest. Usually item generation starts with a group of subject matter experts to start to generate some items. And then you talk to your group of interest and get feedback. And they're like, yeah, forget that. When we were talking to our patient focus groups about patient quality of life, we thought spirituality was going to be really, really important. No, not so much. Now, it's not that spirituality wasn't important to the patients. It wasn't important to them as it related to their health-related quality of life, or even their overall quality of life. So you generate the items, and you keep generating until you have saturated, and you get another group of people and they're like, yeah, there's nothing else. And then, which I don't think was done for the survey that the residents are answering at the end of the site, because it's 67 questions, you have to reduce. Now, sometimes you don't, you reduce and you're like, I can't get it any shorter. Okay. I know you can, but okay, I'll give that to you. You can't get it any shorter. And then you talk about formatting, and do you put the demographic questions first or last? And I know you're gonna have a presentation about demographic questions, and I'm not going to spend a lot of time there. There's a reason to put them first. There's a reason to put them last. And using skip logic. And then the composition, what it looks like on the paper, makes a difference, or on the screen makes a big difference. If it's just text, people will just look at the screen or look at the paper and they're like, yeah, no, delete, throw it in the garbage. And then you should pilot test it. And pilot test it on a similar group that is, that's your group of interest. So if you're going to survey medical students, you should pilot it on medical students. If you're going to survey patients that have had traumatic injury, you should pilot test it on patients that have had traumatic injury. And you can't use those data in your final survey. The pilot testing tells you which questions weren't understandable. So you have the question, and then you actually do have a box that says, I didn't understand this. You should really be asking this. And at the end of the pilot test, you say, what didn't we ask? What should we not have asked? And you get information there. And that actually does allow you to further reduce the number of questions. Different population. It does depend a little bit on how different. For instance, the general quality of life survey of patients was initially validated on patients with depression, heart disease, a rheumatologic disease, a healthy population or an unselected population, and then I think some GI, or might have been hypertension. And that is supposed to be broad enough that you can then use it on somebody with a leg fracture for general health, or somebody with another type of psychiatric illness other than depression, because it was fairly broad and representative. If it is completely cultural differences, it is worth at least pilot testing the validated questionnaire to see if there are problems answering the questions, and comparing an initial pilot administration. And yes, we'll get to the surveys should, in general, be closed-ended and not open-ended. Unless they are surveys about unless you are looking for how to improve something, which is not usually that's not usually a publishable survey. You usually want fixed, closed-ended options for surveys. And in terms of having the options limited, the less you limit the options, the more you're going to combine at the end, because you're going to find small cells in your results and you're going to need to combine them. So you do need to cover all potential options, but within that framework, trying to eliminate trying to limit the options serves you better on the analysis side. The interview administered, you will get a better response rate with interviewer administered, but if you have any sensitive items on your survey, you will have better answers with a indirect dissemination. So these are they're really mostly question don'ts, not question do's. So leading or biased questions. Do you close a contaminated wound? Do you break the rules? No, of course I don't break the rules. I break them almost as many times as I follow them. You do have to follow them more often than you break them, and you have to know you're breaking them when you're breaking them. 2-in-1 questions. Is your faculty member on time, and do they provide good teaching? Well, they're always late, but they're the best teacher we have. How do I answer the question? I can't answer the question as a respondent. And so then as a surveyor, you don't know what the answer means. You don't know if the answer yes means they're both on time and a good teacher. You don't know if no means, well, you probably know yes means, well, you might know. And you don't know if no means they're not on time and they're not a good teacher, or they're not on time but they're still a good teacher, or they are on time and they're not a good teacher. Negatively worded questions. So this is just like a multiple choice question. You don't want to ask a negative. You want to ask it in a positive way. Open-ended questions, as I said, that depends on the intent of the survey. I ask a lot of open-ended questions of my residents, but I'm never going to publish that, and I don't care about the response rate. I just want to gather as many opinions as possible. Incomplete or overlapping questions. So what percent of the time do you get to the operating room as an intern? What percent of the cases? 0 to 25, 25 to 50, 50 to 75, 75 to 100. So how do I answer that if I get to the operating room 50% of the time? Because 50 is in 2 option sets. So it has to be 0, 1 to 25, 26 to 50, 51 to 75, 76 to 100. That would at least solve that problem. And then absolutes. Do you always? Well, no, I never always. Do you never? Well, no, I always never. So you want to avoid always and never, because none of us are perfect. And even though I am always on time, I'm occasionally late. And I will say that, and I will believe it, and it makes no sense. I am always on time, and I'm occasionally late. There's a question about translation. It does not have to be done by a professional translator if you have the language skills. Which brings up another really important point that most of the time we don't do. There are language services in your institutions and also online that will tell you the grade level of any document, and they'll do it in any language. You need to pay really close attention. It should probably, depending on your population, your institution will tell you what, if you're surveying patients, for instance, where you should aim the grade level. If we're talking about students professors, that's a whole different issue. But for patients, they will tell you where you need to aim the grade level. Oftentimes it's a second or third grade level. And that's because oftentimes you will be surveying students, patients, and asking them to answer not in their native language. It does need to be done by somebody that understands. Translation needs to be done by somebody that is a native speaker and understands idioms, but it doesn't have to be a professional translator. So how should we survey? So we talked a little bit about that. It's so easy to survey electronically, right? And you would think that the answer now is electronically. It turns out that the best response rates are with mixed methods surveys. So a combination of some type of I was going to say in-person mail, snail mail, and electronic or email, or some type of phone and electronic or phone and snail mail. Those get the best response rates. It also turns out that if you provide an incentive, so not just incentive in terms of capital, getting somebody that is a part of that group, but an incentive like a pen or $1. Even $1 will do it. Or the opportunity to enter a raffle to get an iPad, or free registration, or I don't know, a gift card, whatever the incentive might be. It does not have to be much, but particularly for snail mail, if you get $1 in the mail and a survey, the obligation you feel to answer that survey, much, much greater than the $1 that was spent. So it does depend on how important your response rate is and how and what survey response rate you're going for, but mixed methods do get the best results. Going just for social media platforms, just on social media platforms where you don't know the denominator, you have to be very, very careful about drawing conclusions. You can get really good information from that, but the conclusions you can draw are much more limited when you can't calculate the denominator. It may be perfectly acceptable for the for your question. So it's not a don't ever use it, but if you really need to show response rates and you're really trying to make a distinct declarative statement, you need to be able to compare responders and non-responders. So imposter syndrome is much more likely to be associated with women from Iowa compared to women from other states in the country. Well, I gotta know that I have enough, I have to know the women from Iowa that responded and how many women from Iowa didn't respond, and how many women from all over the rest of the country responded and didn't respond to be able to make that statement. How many more women on social media report imposter syndrome compared to men, or how many more women ages 50 and above? You might have an issue with the use of social media, but how many more women in the legal profession compared to the medical profession report imposter syndrome? You could use social media as that, but you can't do comparisons without being able to know the denominator. You can't do as many comparisons and can't be as declarative about them. Another really good question. The incentive has to be small. So it is not seen as coercive. Like I say, $1 will do it. $50 gift card, $25 gift card, 1,000 people are entering, you sent it to 1,000 people, $25 gift card. not a big incentive, just enough. It just trips something in most of us. So this is how, there are 6 ways to calculate response rates, according to the American Association of Public Opinion Research, AAPOR. It's responders over non-responders. And the 6 different ways are how you count the responders and how you count the non-responders. The easiest way is to say, well, all non-responders were eligible. That's probably not true. If you sent a survey to the 7-Eleven store, that non-responder really wasn't eligible because that's not an eligible address. Even though it was in the field, it's not an eligible address. So you need to, in both your responders and non-responders, check the addresses on a sample of each. And then there's a mathematical equation, and you can find this. I don't even know why I put it here, because it's not something you should ever put on a slide. Then the numerator, some will use 50%, the recommended number is 80%. It has complete responses to a minimum of 80% of the questions. Or an alternative definition, which I like better, 80% of the questions of interest. So if they don't answer the demographic information, particularly many survey questions, the demographic information isn't all that germane. Sometimes it's exactly what you want, so you, and exactly what you're trying to analyze by. But you do need to either say you don't know the denominator and you are solely focusing on what the respondents said, or this is identify which method you used. And then you need to compare. You need to compare to look at non-response bias. So if 27% of people responded and they all responded positively, I think whatever I'm surveying about is great. Well, it may be that the 73% all thought it was horrible. They just didn't respond. And so I actually may have a completely incorrect conclusion. So you have to compare the respondents and non-respondents. You also want to compare those that answered at the beginning and those that answered at the end. Oftentimes those that answered at the end are more similar to non-respondents than those that answered at the beginning. And if you have the ability to compare to a gold standard or an external source, that is optimal. When you do your statistical analysis, many times people use parametric tests, and depending on the sampling frame and how complex the sampling frame is or was, you have to use non-parametric tests. So that's the first thing to check. And again, depending on how complex, you may need to use sampling weights. In terms of, I was told once by somebody who was a cousin of the man that this is pronounced Likert instead of Likert. But should you allow a neutral option? So it depends. Most of the time, I think you really want to be able to force people to say, I either disagree with it or I agree with it. And then you want the strength of that agreement or disagreement. However, sometimes people really don't care. And so there isn't a specific rule about this. In general, most people would say if you cannot use a neutral option, choose not to use a neutral option. You will find that out in your pilot testing. People will be really angry if they really wanted to choose a neutral option and you didn't give it to them, you'll hear about it. And then most times, just to get statistical power or statistical significance, people will combine strongly agree, and strongly disagree and disagree. If you don't have to, don't do it. It gives you more information to know the strength, but most of the time people will do that, and that's okay. So I have some examples, but we are up at time, and this is just, we've gone through most of this information, so I don't think we don't think we need to do this. This is just some examples of some pitfalls. So I'm going to stop this because I don't want to bleed into other people's time. But you really need to have a good answer as to why you are using a survey and not using something else. And the first thing you should kick around in your research collaborative group is the survey the best way to answer this question? Or if it's not best, is it at least acceptable? Pay really close attention to question development and get a lot of feedback. There is no one right way for implementation. Response rate, your implementation is really driven by two things: how quickly you need the information. Are you going for just, I need to use this to better my program, whatever that program is, or am I really going for publication? And then know how you're calculating the response rate and know some of the common pitfalls. I will give you I will give Hannah my slides, and then it's also on the recording, but if you want to look at some of the pitfalls later on, you certainly can, any of you can have access to the slides. So thank you very much, and thank you to all of you for engaging in the chat. I do know this is difficult, and I am thankful and grateful that it's people from actually around the world were able to participate. So Hannah, thank you again for the invitation and opportunity. And I didn't think I had 60 minutes of content, but I guess I did.
No, thank you. Thank you so much, Dr. Brasel. We really appreciate it. And thank you to everyone for your engagement with the chat. I think we answered most questions as we sort of went along, but I'll give anybody the final opportunity to ask a question if they had any sort of lingering things that they wanted to know. Oh, that's nice positive comments in the chat as well, Dr. Brasel. So with that being said, thank you so much for providing us with your time and expertise. This was an excellent dive into survey research, and I look forward to seeing the results of everyone's future survey projects, hopefully soon. So just a few sort of final points. So in the coming days after this session, we're going to be sending out a takeaway document. So Mary and I have been compiling key pearls of wisdom and advice from Dr. Brasel, and we're going to be putting these together in a bullet point review for you to consult at a later date if you'd like. Mary is also going to post a feedback form right now. Yes, she's posted that. And we would greatly appreciate your feedback so we can work to strengthen future sessions. And we also wanted to take this time to let you know about our next workshop, which will be on March 13th. We'll focus on health services research with Dr. Amir Ghaffari, who's an expert in the field as well. And Mary is going to post the registration link for that as well, so you can sign up. We'll also send it out via email. So coming up next, we have a special collaborative workshop with the Gender Equity Initiative in Global Surgery. This part of the workshop will focus on gender inclusivity and survey design. So don't worry, we're going to take a quick 5-minute break. You can stay on this link though, but please feel free to sort of get up, stretch your legs, and rejoin in a little bit. Thank you again, Dr. Brasel.